गुड इव्हनिंग.
माझा आवाज
गुड
ऐकू
इव्हनिंग
येतो ना
सम्राट.
सर? गुड इव्हनिंग दीपक सर.
गुड इव्हनिंग. गुड इव्हनिंग. येस येस, आवाज येतोय
येतो
सम्राट. येस.
येतो
ओके.
व्यवस्थित आवाज येतो. ओके.
सर एकदा स्क्रीन शेअर करून बघतो, जस्ट प्ले
येस,
होतीये का एकदा चेक करून घेतो.
प्लीज प्लीज.
स्क्रीन दिसतीये सर?
येस.
सर फुल स्क्रीन आहे का? आता अजून एक्सपांड करायला पाहिजे.
ऍक्च्युली फुल स्क्रीन नाही दिसत आहे. ते
एक
तू
सेकंड सर.
वरचं मॅक्झिमाइज केलं तर होईल मला. हा, येस येस.
आता बेटर आहे ना सर? राईट.
हा, दिस इज बेटर. येस येस.
ओके. चालेल सर, ठीक आहे. ओके.
ओके, थँक्यू.
थँक्यू.
सर, क्रम कसा ठेवायचा आहे आपल्याला सर? सर, क्रम कसा ठेवायचा आहे? आधी डॉक्टर
आधी
सम्राट करणार आहेत का मी करू?
हो, आधी सम्राट सरांना करू देत, मग बोर्डे सर. चालेल.
चालेल.
ओके.
चालेल ना सर,
चालेल
मला
सर,
काही
काही
प्रॉब्लेम.
प्रॉब्लेम नाही.
येस येस येस,
ऍब्सोल्युटली काही
ऍब्सोल्युटली.
प्रॉब्लेम नाही.
बालाजी सर जॉईन झालेत का?
नाही, अजून दिसत नाहीये.
नाही ना. विकास.
सर सर जस्ट फ्री झाले होते 15 मिनिटापूर्वी. जॉईन होतीलच सर
दीपक,
आता.
गुड इव्हनिंग. सम्राट, गुड इव्हनिंग. गुड इव्हनिंग
सर
एव्हरीवन.
गुड इव्हनिंग. गुड इव्हनिंग
गुड
करेंगे
इव्हनिंग
सर.
सर.
गुड इव्हनिंग.
अविनाश. विकास जॉईन झालाय. अविनाश. अविनाश सर, गुड इव्हनिंग. डॉक्टर अविनाश सर. अविनाश सर सध्या
हेलो।
काश्मीरला आहेत.
मैं अभी ट्रैवल कर रहा हूँ, कैंप से बाहर नहीं आ रहा हूँ, अभी हॉस्पिटल से रूम जा रहा हूँ, तो जरा बहुत आवाज है इधर, ट्रैफिक
चलेगा
बहुत
सर.
है। आई
ओके
विल
ओके.
ज्वाइन आफ्टर 5 मिनट्स।
ओके ओके, नो प्रॉब्लेम सर. ओके. अविनाश सर सध्या काश्मीरला आहेत, एका कॅम्पमध्ये रोटरी क्लब कडून एक चांगल्या कार्यासाठी गेलेले आहेत. ते आता रूमवर जाऊन मग जॉईन होतील.
Hello, good evening, Rajesh sir. Dr. Bhavesh here, Pimpri
येस.
Chinchwad.
गुड इव्हनिंग
Good
भावेश.
evening, sir.
Good
गुड
evening.
इव्हनिंग.
Good
Good evening,
evening.
everyone.
गुड इव्हनिंग
Good evening,
एव्हरीवन.
everyone. Hello.
Yes.
हॅलो. शीतल मॅडम, गुड इव्हनिंग.
Hello.
शोभा मॅडम, गुड इव्हनिंग. गुड इव्हनिंग ऑल.
Good evening, Dr. Rajesh, Dr. Karkade. Good evening.
गुड इव्हनिंग.
कातकडे सर, गुड इव्हनिंग.
Good evening, good evening. How are you?
गुड इव्हनिंग सर.
Fine, sir. Thank you.
How is everybody? Fine. Chan. Good, good. Nice to see everybody.
So just
We'll
tomorrow
wait.
also we are conducting webinar from our SAPC members only. So त्याच्यासाठी पण please everybody log in. I request on this platform also.
ओके. येस शुअर.
Thank you.
बालाजी सर. गुड इव्हनिंग बालाजी. हॅलो. We'll wait for Balaji sir for 5 minutes. Shall we?
Good evening.
Good evening,
Yes.
sir.
Yes. Balaji sir has joined.
Yes.
गुड इव्हनिंग सर.
Good evening, Balaji
Good evening,
sir.
good evening, everyone.
Tomorrow we'll be having another session, a very
Yeah.
live session, crash but control. So please attend in the large number. This is by 6:30 onwards.
Definitely try to join.
Thank you, sir. Thank you.
Okay, sir.
Shall we start Balaji?
Yes.
Okay.
But is it, I think we'll start after 1 or 2 minutes. 6:30 it is not yet.
Okay.
6:29.
Okay.
I think we should wait for 2 minutes.
Yes, yes.
विकास सर, गुड इव्हनिंग.
Sir, good evening.
Good evening, Vikas sir.
Good evening.
Deepak has joined.
Yes.
Deepak,
येस सर.
Deepak
येस
is
सर.
there.
Okay, okay.
येस सर, जॉईन केलं, चेक पण करून बघितलं, स्लाइड्स
Okay.
येस.
Rajesh, can we
Yes.
start now? 6:31, I think.
Okay.
Yes.
Good evening, all dear respected seniors and friends. With new concept of SAMS webinar on a recent advances today, we are here with the recent advances on intraoperative hypotension and its outcome by Dr. Samrat Madnaik from Karad, and recent advances anesthesiologist as a echocardiographer by Dr. Deepak Borte sir from Aurangabad. Dr. Samrat Madnaik sir is a consultant cardiac anesthesiologist from Karad, and Dr. Deepak Borte sir is also a consultant cardiac anesthesiologist at Ozone Anesthesia Group, Aurangabad. I would request Dr. Balasagokar sir, President SAMS, for a welcome comment.
Good evening to all. This is our second activity on recent advances, and our last activity was attended by 100 delegates online, as well as I think it is watched by more than 100 by YouTube link. And considering this huge response, we want to continue this recent advances series every month, and it's on last Wednesday of every month. So I request all of you to please pass on this to all your local groups. And today we have very exciting topics, and very young dynamic speakers are agreed to talk on this. So I wish best of luck to both of them, and I request Rajesh to please continue with the proceedings.
We'll start the webinar. I would like to request Dr. Vikas Karne to introduce Dr. Samrat Madnaik sir.
Good evening to all, and welcome to this exciting webinar today. So we have my friend Dr. Samrat Madnaik here from Karat. He is MD and done DM in cardiac anesthesia. He has also done fellowship in transesophageal echocardiography, fellowship in cardiac critical care. He also has a gold medal in health research exam, which was conducted by ICMR. And he's been practicing as a cardiac anesthesiologist, and he's going to speak to us about the recent advances in intraoperative hypertension and its management. So, Dr. Samrat, please.
Next, sir, thank you for the wonderful introduction. First of all, let me thank Society of Anesthesiologists, Maharashtra State, for giving me this opportunity to present at this prestigious platform. Good evening, dear friends, my seniors, colleagues, and everyone. Myself, Dr. Samrat, and today I am going to talk on intraoperative hypotension and outcomes, and will look about the recent insights. I hope my screen is visible to everyone.
Yes, it is.
Yeah, okay. So disclosures, anything wise in the presentation, you should credit it to the many experts who have preceded me. Anything foolish, please assume it my error. I'm not associated with any commercial companies, and I'm sharing these insights based on my personal understanding. These are the objectives of my talk. First of all, we'll look at the history and definition of intraoperative hypotension. We'll look about the different outcomes. We'll look about the recent prediction algorithms which are currently in use, and there will be a take-home message at the end. I always wonder how they used to anesthetize the people in olden times. Maybe like this. I'm glad that I'm not in the olden times, otherwise this talk wouldn't have had been happening. A brief about history. Gardner in the year 1946 first tried to have deliberate intraoperative hypotension in his patients to control the bleeding intraoperatively. So this was probably the first time that intraoperative hypotension was being studied. That was way back in the year 1946. Further, Enderby in 1950 tried to work on this concept of intraoperative hypotension, and his work is also remarkable. As the decades progressed, R. Larson, who was a German anesthesiologist, also tried to work on intraoperative hypotension. But he found that complications are rare with patients who were healthy, but they were higher in elderly patients and those who had underlying organ dysfunction. So the severity of intraoperative hypotension was first described by R. Larson way back in 1995. After that, the concept of intraoperative hypotension started to gain momentum. Now, the human mind always has the fear for unknown. We try to create monsters out of small things. Even if the problem is so small, we try to create a monster out of it. So whether intraoperative hypotension is a monster or not, we will see. I like to compare the intraoperative period with marriage. And why do I say so? I'll explain it to you at the end of my talk. Both intraoperative period and marriage are important events in the life. Similarly, marriage has different definitions. Similarly, intraoperative hypotension does not have one single definition. If you go across the literature, you will find different researchers trying to define intraoperative hypotension in their own terms and with different definitions. So if you go through the literature, you will see that there are around 140 definitions in 130 articles, wherein systolic BP of less than 80 mm of Hg was found in 41% of the patients. Systolic BP of less than 20% from the baseline was found in 93% of the patients. As such, if we take all these articles into consideration, the incidence of intraoperative hypotension comes from 5 to 99%. And unfortunately, there is no consensus on the definition of intraoperative hypotension as of now. Now, look at this image. These all people are working in synchrony. That's why this boat is moving very harmoniously. Similarly, for circulation to occur in a normal way, we require 4 parameters to work in synchronization. These 4 parameters are the preload, contractility, afterload, and there are a few other factors. Coming to the etiology of intraoperative hypotension, intraoperative hypotension can be caused due to reduction in the preload. It can be also caused due to reduction in the cardiac contractility. It can be due to reduction in afterload and other causes like pregnancy, positive pressure mechanical ventilation, pneumothorax, or some kinds of embolisms like fat or CO2 embolisms. Now look at this image. What is happening here? So in this image, in this particular patient, we see the cardiac output is 2.1, which is very low. The stroke volume is 25, which is again very low. If you see, the CVP is 3. So what do you have to guess about this? I'll give you some more clues. This is the transthoracic echo image. You see the IVC is collapsing. The diameter of IVC is also less than 2.1 and the collapsibility is good. Also, if you see in this image, there the ventricle appears to be underfed. So basically this patient is preload deficient, and that is the reason why the patient is having intraoperative hypotension. So this is one of the most important factor, that is preload deficiency, which causes intraoperative hypotension. Now look at this image. What is happening here? Again, we have a cardiac output which is very low. Here the arterial BP is also very low, but the CVP is very high. What could be the causes? Look at the echo image here. What do you see here? So the distal interventricular septum, the apex, the apical region appears to be severely hypokinetic, or it is rather akinetic. If we run a strain analysis on the same patient, we will find that the global longitudinal strain is -1%, which is very low. So it is very clear that the cause of hypotension in this patient is reduced contractility or regional wall motion abnormalities. Coming to the third important cause of intraoperative hypotension, and the cause can be afterload. Now, if you look at this image, what do you see here? Here, the patient is having tachycardia. The arterial BP is again towards the lower side. CVP is high. But if you look at the echo image here, you will find that the patient has hypertrophied ventricle. So this is a patient in which the patient had obstructive hypertrophic cardiomyopathy. You can see the dagger-shaped pattern of the Doppler in the LVOT of the patient. And as a result of this patient had intraoperative hypotension. So intraoperative hypotension can be due to decreased preload, it can be decreased due to decreased contractility, or it can be due to the afterload conditions of the heart. Now, there are 5 main elements in the nature. These are the sky, air, water, land, and fire. Similarly, whenever we talk about intraoperative hypotension, there are 5 main outcomes which we are looking at. So what are those 5 main outcomes? But before we go to those 5 main outcomes, let me take you to one research which was conducted way back in 2010. So this was called as the POISE trial. So what the researchers tried to do was, the researchers tried to give beta blocker in the form of metoprolol to all the patients who were subjected for non-cardiac surgeries, and they tried to look at the post-operative outcome of the patients. The researchers were so sure that the myocardial incidences or the post-operative outcome in the group of patients who had received beta blockers would be definitely better. But surprisingly, when the results came, there were more deaths in the metoprolol group than in the placebo group, and more patients in the metoprolol group had incidence of stroke. And this was related to the intraoperative hypotension which was caused by metoprolol. So as such, intraoperative hypotension carries major risk, and one of the major risks is stroke. So even before the findings of the POISE trial were out, the researchers were very confident that metoprolol is good and should be prescribed to everyone. But we should never celebrate too early, or the results can be disastrous. So coming to the first outcome, that is stroke. So Bijkar et al. In their study found that 30% reductions in the mean blood pressure from the baseline were significantly associated with postoperative stroke in patients undergoing non-cardiac and non-neurological surgeries. Coming to the second outcome, that is delirium. The researchers found that lower mean arterial pressures of less than 55 mm of Hg were associated with delirium, and fluctuations in the blood pressure and longer duration of surgeries had more correlation with the postoperative delirium rather than an absolute value. The third and the important outcome of intraoperative hypotension is acute kidney injury. Now, Wash et al. In their study found that AKI incidence was more with intraoperative mean arterial pressures less than 55 mm of Hg. If you look in this image over here, the intraoperative mean arterial pressures, when dropped below 55 mm of Hg, the incidence of AKI was more. Similarly, Sun et al. In their study found that the intraoperative hypotension when the range of intraoperative hypotension was less than 60 mm of Hg for more than 20 minutes, or it was less than 55 mm of Hg for more than 10 minutes, then the incidence of AKI was more. And they defined AKI as more than 50% or 0.3 mg per deciliter increase in the serum creatinine concentration. So basically, intraoperative hypotension, when lasts for more than 20 minutes or more than 10 minutes, the value of 55 mm of Hg, it is associated with more incidence of acute kidney injuries. Coming to the myocardial injury. So researchers have found that systolic blood pressure of more than 50%, decline in the systolic blood pressure of more than 50% from the baseline lasting for more than 5 minutes can cause myocardial damage. Now look at this image. You should always know what you are looking for. So this situation can be very disastrous. So finally, in intraoperative hypotension, what we are looking for is 1 year mortality. So Monk et al. In their study found that when the systolic blood pressure was less than 70 mm of Hg and the mean arterial pressures when were less than 50 mm of Hg, or when the diastolic blood pressures were less than 30 mm of Hg, then the 30-day mortality was very high. Regarding the 1-year mortality, again, Bichkar et al. Has conducted a study, but there is no causal relationship between intraoperative hypotension and 1-year mortality. And the effect of intraoperative hypotension on 1-year mortality remains debatable at the end of 1 year. So there are major 5 outcomes of intraoperative hypotension which we should be aware of. Regarding pediatric subsets, there is no consensus as to what constitutes intraoperative hypotension in children. In children, O2 saturation always takes priority over BP during induction, and respiratory events are still the major cause of anesthesia mortality in healthy children. Now, researchers found out that when low blood pressure, low bispectral index, and low minimal alveolar concentrations were combined together, then they could predict the increased mortality or morbidity in the perioperative period, especially in non-cardiac surgeries. So this was the concept which was in place recently. But now there are a few articles which state that this concept does not hold true. So again, this is a controversial topic. Few people believe that triple low can cause hypotension and increase mortality. A few believe it doesn't. Now look at this image. What do you see? The children are sitting on the wall. But how is that possible? Now we can just change our perspective and we'll find the real truth. Similarly, our perception till now is a normal blood pressure means that everything is okay. Now, these are the images of intestinal gut microvilli. So these are the microcirculatory images. You see, this is the image taken during baseline. That is when the patient does not have intraoperative hypotension. With 10% hemorrhage, you can see the flow of the microcirculatory flow in the gut intestinal microvilli is changing. So at this particular point, when there is 10% hemorrhage, even if the BP appears normal on the screen, microcirculatory changes are in place. Similarly, when there is 20% hemorrhage, and if we have used a vasopressor, even if the numbers on the monitor appear normal, that is, you do not find intraoperative hypotension on the monitor, but at the microcirculatory level, definitely changes keep on happening. So the recent concept is a normal blood pressure does not mean everything is okay. So what then? Is there a need for prediction of intraoperative hypotension? Definitely yes. Now look at this graph. So this is a graph of a patient, and we have plotted the time on the x-axis and mean arterial pressures on the y-axis. So here you see till around 10 minutes, the patient does not have intraoperative hypotension. After 10 minutes, the patient is starting to show signs of intraoperative hypotension, that is mean arterial pressures going below 65 mm of Hg. This dotted red line is mean arterial pressure of 65 mm of Hg. Somewhere here at around 24th or 25th minute, the anesthesiologist has intervened, and because of his intervention, now BP has picked up again, and again the BP is stable. But now the question is whether we can predict that this patient can have intraoperative hypotension. If we were able to predict initially at the beginning of surgery, or at least 5 to 10 minutes before this event occurred, then we could change the outcome of the patient. The patient would not have gone on this trajectory. Rather, the patient would have traveled on a trajectory that is the green trajectory, and he would not have had the intraoperative hypotension. So from old times, Socrates used to try to predict the future. Even if there are any Marvel fans out here, you know, Doctor Strange tries to predict the outcomes in million ways. The exit polls are also so accurate these days that they can predict the outcome in a proper way. Even in cricket, our Captain Cool used to predict the pitch before any match. So can we predict whether the patient can have intraoperative hypotension? Till now, we were all relying on the descriptive parameters. These are the descriptive parameters, because of which we were not able to predict whether the patient could have intraoperative hypotension. But with the invention of HPI, that is hypotension prediction index, this is a technology that basically predicts the patient trending towards an hypotensive event. So let us look what this HPI is all about. So all these years, we were into the descriptive phase of the numbers. Now slowly we are moving towards the predictive phase, that we are trying to predict whether the patient can have hypotension or no. And also we are also trying to move towards the prescriptive phase, like depending upon these predictions, we are trying to
गणेश गणेश आवाज येत नाहीये.
हॅलो डॉक्टर सम्राट डिस्कनेक्ट झालं मला वाटतं.
डिस्कनेक्ट झालाय.
सर त्यांचं नेटवर्क प्रॉब्लेम आहे बहुतेक. हॅलो.
राजेश
हॅलो हा
सम्राट
हा
फोन करतो sir.
हा सर आवाज येतोय का?
तुझा
येस
येतोय
ही
आवाज?
रिजॉईन
Sir, sorry for
Hi.
the interruption. Some problem with the network, I guess. Just a minute. Let me share my screen again.
येस.
Is it visible, sir?
येस
येस.
Yes.
Yeah. Okay. I hope we are on the same page, and I was talking about this.
Yes, yes,
Or
Samrat.
is
Yes.
yeah. So yeah. So it all started when Samir et al. Tried to see whether patients who were subjected to anesthesia were having hypotension after the induction. So he studied around 13,323 patients. And with the help of machine learning algorithms, he found that machine learning algorithms have a positive predictive value of around 96%, and they can predict whether the patient can have hypotension or no. So based on this research, further, the researchers looked at the arterial pressure waveforms, and about 2.6 million features of arterial pressure waveforms were seen. They were subjected for machine learning, that is deep learning, and out of this 2.6 million features, around 23 predictive features were selected, which mostly comprised of aortic compliance, stroke volume, vascular tone, afterload, and contractility. And based on this 23 predictive features, an HPI algorithm was developed, and we got the invention of HPI, that is hypotension prediction index. So the HPI prediction model was developed by Hatib et al. With the help of machine learning. The HPI can predict a hypotensive event defined as a mean arterial pressure less than 65 mm of Hg for more than 1 minute, 5 to 15 minutes before this hypotension actually occurs. So basically the HPI is a number ranging from 0 to 100, and the machine will give you a value. Higher the number, higher are the chances that patient can have hypotension in the coming 5 to 10 minutes. So if you look at the literature, then you see that when the HPI values are between 85 to 89, the event rate of hypotension is around 89 to 90%, and the time to event in minutes is around 5 minutes. So when the HPI number is above 85, 90% of the patients can have hypotension, and that will be given to us. This information will be given to us 5 minutes before actually these patients have hypotension. So this is how an HPI screen looks like. So we have an HPI number over here, 86, which is absolutely high. We have a mean arterial pressures, we have cardiac output, we have SVR over here. There are some other parameters like stroke volume variation, that is SVV, which is an parameter for the assessing the preload of the heart. We have a dP by dt, which is a measure of contractility of the heart. And we have EA dyne, that is dynamic arterial elastance. So basically dynamic arterial elastance means when if you give fluid to the patient, whether this patients will respond to the fluid, that is whether this patients when given fluid, whether the actually BP will increase in this patients. So whenever EA dyne value is more than 1.2, usually this means that these patients with having EA dyne values of more than 1.2 will respond to the volume and their BP will increase. So stroke volume variation is basically a preload character. dP by dt is a measure of contractility. dP by dt is measured non-invasively in this case, and it depends upon the upslope of the arterial trace. And dynamic arterial elastance is nothing but it is the ratio of PPV by SVV, that is pulse pressure variation by stroke volume variation. So let us look at one of the simulations. So this is basically a simulation. This is not a real-time patient. So let us see what is happening here. Now, this is the beginning of the surgery. We see the BP is normal. It is around 113 by 60. And we have an HPI value of 34, which is fairly good. That means the patient mostly will not have hypotension in the coming time. Now, let's see what is happening further. Now, as the surgery is progressing, let us keep a watch on the HPI. So at some point of time, the HPI is starting to increase. Now it has become 50. Still increasing, it has become 69. Still increasing, now it has become 87. And you can see the stroke volume has decreased. We'll wait for some more time, and now the HPI will increase more. So now the HPI has reached 95 and the machine has given us a pop-up. So basically the machine has given us an HPI alert. This HPI alerts, we can set the values. So now the HPI value is 95. That means definitely the patient is going to have hypotension in the coming time. If you see on the real-time screen here, the BP is still 93/46. Mean arterial pressures are still good. So that is not a worrisome thing for us right now. But according to HPI, definitely this patient is going to have hypotension. So let's see what the machine has to tell us further. So we will click on more information. Once clicked on more information, we will get this screen. Now what has happened here? We are having an HPA value of 97. We are having a cardiac index of 2.5. We have a stroke volume of 61, which is slightly lower. We have stroke volume variation of 18, which is quite high. We have DP by DT, which is 520, which is fairly okay. And EA-dyne values of 1, which is slightly higher. That means definitely this patient is preload deficient. So let us try giving volume to this patient. We'll try to infuse volume to this patient. So now we have selected the parameter of infusing crystalloid to this patient. And after infusion of the crystalloid, let's see what happens with the HPI values. So see, immediately after infusion of the volume, the HPI values have started to go down. The stroke volume which is there, it has started to improve. Our hemodynamics are better and HPI value is still decreasing. That means now the patient is adequately managed and the chances of hypotension in the coming time are very less. So this was a simulation. Now, similarly, we were looking at the predictive domain of HPA. Similarly, now with the recent advances, we have fluid meters which are available. So these fluid meters, basically, these are connected to the IV points of the patient. And there is an algorithm again, in which we can feed how much fluid is to be given to the patient. And this algorithm is synchronized with the HPA. So basically what will happen once you connect the fluids to this fluid meters, and once you synchronize this fluid meters with your monitor, depending on the HPI values, the monitor or the machine itself will deliver fluid boluses to the patient. So you can set how much volume, total volume you can give to the patient through the entire duration of the case. So these are the recent advances which are occurring recently. Similarly, other algorithms are being developed currently, and these are the HPI algorithms, and they will help us in the coming future to diagnose and guide our treatment regarding the intraoperative hypotension. Now, you might ask me, for all these methods, we will require an invasive blood pressure monitoring, but that is not the case. HPI can also be detected or done with the help of non-invasive monitoring. So basically, this is a non-invasive monitor of HPI, which is available. And there is a occlusion device which is placed on the wrist, and there is a tracker on the finger. And basically, this is non-invasive. So this is connected to the machine, and in real time, this is the screen that you get. So here, this is a physiological screen, what you are seeing. You are able to see the cardiac index. You are able to get the HPI value. You are able to see the stroke volume, and you are able to see the cardiac output. Basically, this is a normal subject, non-anesthetized subject. So HPI value is very low. And this is the screen that we see. In real time, without inserting an invasive arterial line, you are able to see the arterial trace. So this is a real-time recording or a real-time monitor. You can see the cardiac index, the HPI value, the systemic pressures, the stroke volume variation, the EA-dyne, the DP by DT values. All these values are found on the monitor. So based on these values, definitely we can guide our patients. Now there are different studies which are being done currently regarding this HPI. A few studies have been completed. And some of these studies state that HPI has shown to reduce the exposure to intraoperative hypotension. Similarly, one of the study in European countries, which was the EU Hyprotect, concluded that using HPI software monitoring can reduce the duration and severity of intraoperative hypotension in patients posted for non-cardiac surgeries. So still a few trials are underway. Let us see what the results come in the coming years. Now look at this image. What is happening here? Some person is trying to meet people in the flood affected area In the second image, a child is being subjected to violence. Now the actual reality is this. So what about the actual reality of HPI? So there are a few articles which also state that HPI is not as good as projected, and there are some fallacies in this HPI, and which can be contributed to the lack of knowledge of the treating physicians or the treating anesthesiologists, which are not well versed with this technology. Similarly, there are a few articles which say that performance of HPI prediction index may be overestimated due to selection bias. Now, whether HPI is a fluke or whether in real time it will help us, only the coming time is going to guide us regarding all these things. But definitely, as of now, HPI is a great technology, and it can be advocated for research as well as guiding the patients who are under high risk categories. Now, there are also a few non-invasive devices which can give us inputs into the cardiac output and a few of the other parameters. A few devices are based on electrical impedance. A few devices are based on pulse wave technology, that is the pulse wave transit time technology. And depending upon these algorithms, that is the artificial intelligence algorithms, they can give us values of cardiac output. So these devices are also in market. What about echo and hypotension? Whether echo can predict hypotension. So prediction of post-induction hypotension by point of care echocardiography is definitely possible, and there is a lot of literature regarding this. Basically, in echocardiography, the IVC collapsibility index, similarly the SVC variation or the peak VTI variation can give us insights whether the patient can have hypotension after anesthetic inductions. So a lot of research is being currently done on this, and definitely all anesthesiologists should be well versed with this technique of echocardiography. So a few of clinical experiences that I had. So this was one patient which was posted for vascular surgery. Basically, he was posted for RFA ablation, and our surgeon used to like to have the patients under general anesthesia. The patient after induction had hypotension, and which was not responding to the conventional treatment, that is volume. So fortunately, this case was taken in the cardiac OT and had a TE probe. So I made use of this transesophageal echocardiography, and I found that on running the strain analysis, the inferolateral bullseye showed strain parameters which were increased on the inferolateral part. So basically, the problem with this patient was regional wall motion abnormalities, and we suspected that the patient had some myocardial event. Fortunately, the surgery went uneventful. It was a quick surgery, and post-operatively, we subjected the patient for angiography, and the patient had a lesion in the right coronary artery, as you can see here. So echocardiography is a great predictive tool. Similarly, another case which we had, this was a non-cardiac patient who was posted for orthopedic surgeries. Unfortunately, in the post-operative period, he had pulmonary embolism. These are the TE images. This is a 3D TE image of pulmonary embolus in the right pulmonary artery. This is another patient who had renal cell carcinoma, and there is a big thrombus into the IVC, hepatic part of IVC. So you can see here. So echocardiography plays a very important role. Another interesting case which I had, one of the patient was posted for an umbilical hernia surgery, and he had come just for a routine screening. I usually have the habit of doing screening echoes for all the patients. So in this particular patient, I found the RA and RV to be dilated, which gave me the suspicion that patient can have some congenital heart disease. Especially these patients are, whenever you find an RA or RV which is dilated, these patients are most likely to have ASDs. And our guess was correct. So we subjected this patient for transesophageal echocardiography, and the patient had an SVC type of sinus venosus ASD. So the non-cardiac surgery was initially deferred, and we subjected the patient first for cardiac surgery. His SVC type of sinus venosus ASD was repaired first, and later on he was subjected for the umbilical hernia repair surgery. Similarly, nowadays automated portable echo devices are available. So in the coming time, artificial intelligence and these portable echo devices are going to play a great role. So there are many modalities which are available, which we can use for treating intraoperative hypotension. TE, similarly invasive catheters, and as I said, HPI can be great tools, and we all should have knowledge about all of these technologies. So my take-home message is a systolic BP of less than 90 mm of Hg, diastolic BP of less than 45 mm of Hg, and mean arterial pressures of less than 65 mm of Hg is definitely associated with poor outcomes for patients, especially posted for non-cardiac surgeries. there is still no definitive answer for what is too low or what is too long, especially in regards to intraoperative hypotension. Predicting, preventing, and managing intraoperative hypotension is a skill which everyone should master. We should get acquainted to the newer technologies, especially like echocardiography. In near future, AI is going to guide prediction and treatment domain. I began my talk with comparing intraoperative hypertension with marriage. And why do I say so? So, for good outcomes, we should always respect intraoperative hypertension. If we don't respect or if we ignore intraoperative hypertension to some extent, definitely we will be having some problems. If you are going to ignore intraoperative hypertension for a long time and for too low, then definitely there is going to be big problem. For good outcomes, definitely we should be looking at intraoperative hypertension in a more holistic way. These are a few of my references. Thank you.
Thank you, Dr. Samrat. It was an excellent presentation. And the analogy that you have used to describe the importance of hypertension intraoperatively, I think none of the people who are attending it will ever forget. So, good correlation. I think it is very elaborative in terms of what you have described about hypertension prediction index, which is a very upcoming thing. And I'm sure in coming days, it will be a norm for all of us to use it, not only in the cardiac OT, but in all OTs. It was very good that you also shared some of your experiences related to the echocardiography in non-cardiac surgeries, because many times we face such situations where there is hypertension and we just keep on giving fluids, or maybe we add inotropes, but we don't really understand what is happening inside. So bedside echocardiography or TE, whatever is available, must be used, and we all should also be, trained to use that tool as our second stethoscope or a modern stethoscope in the OT. I think that is what Deepak is going to talk after you once you finish. So, firstly, congratulations for an excellent talk. And
Thank you,
if
sir.
there are any questions, I think we can take them up.
Yes.
Or should we take the questions last after Deepak?
Yeah, I think we
Yes,
can do that so that both of them can answer questions because
yes,
both are interrelated topics. So
yes, we should take in the last only.
And those who want to ask question, please write it on in chat box.
Chat box, yes.
Thank you,
Dr.
sir.
Dr. Anita Nehte ma'am will be taking question this session.
Yes.
Excellent talk and very informative talk by Dr. Samrat. Thank you so much. Now I would
Thank you,
like
sir.
to request Dr. We'll move to second talk now. I would like to request Dr. Avinash Bhosle sir to introduce Dr. Deepak Borte sir.
Rajesh, I think Avinash is not there. You only introduced. He left
because
because he
he
had
has
some
a
problem.
issue, so he has requested to go ahead with.
Yes.
Okay. Ganesh, introduction slide. Share
Please
करा.
stop sharing.
I think, okay, I have already started sharing the screen. I have stopped sharing now.
Sir, it's visible.
Yes. Dr. Deepak Prakash Borde, he is a consultant cardiac anesthesiologist, Ozone Anesthesia Group, Aurangabad, Maharashtra. He has done fellowship in cardiac anesthesia from Jaidev Institute, Bangalore, fellowship in transesophageal echocardiography from Indian and European Board. He has done advanced PT exam by National Board of Echocardiography, USA in 2019. He is a winner of prestigious Janak Mehta Best Paper Award in the National Conference 3 times. IACTA Kochi 2013, IACTA Mumbai 2014, and IACTA Chennai 2016. He is on the editorial board of Annals of Cardiac Anesthesia and IACTA Echo Library guest reviewer of JCVA. He has published 25 original articles in the Journal of Cardiothoracic and Vascular Anesthesia, Annals of Cardiac Anesthesia, and Indian Journal of Anesthesia. He has conducted 2 national level surveys on the practice pattern of TEA and CPB in India. He has done 2 multicentric studies in cardiac anesthesia also. Dr. Deepak Borde, sir, please start your talk.
Thank you very much, the organizers, and I'm really thankful to the office bearers of SAMS to giving me this opportunity to present on this platform. And the topic which was given to me today was anesthesiologists as echocardiographers. What are the recent advances? So I have no disclosures, but the brief outline of my talk will be why anesthesiologists as echocardiographers. Then we will just briefly see about some basic FATE views, that is focus, assess, transthoracic echo views. Then some of the advanced FATE views. And with the help of these FATE views, how we can derive 5 important numbers or calculations. Actually, Dr. Samrat has set in the perfect platform for me because he has shown how these numbers can be derived on a monitor. So we will try to see how we can derive these numbers using echocardiography. And they are CVP, LV function, RV function, PA pressure, which is one of the very important predictor of adverse outcome. Can we measure cardiac output based on echocardiography? And what all are the recent advances based on artificial intelligence in echocardiography? So I'm not here to talk as a cardiac anesthetist because in cardiac operating rooms, transesophageal echo has clearly set in its role, and now it's an integral part of almost all the modern cardiac operating theaters. But here I am to tell you that why every single anesthesiologist should learn echo, because we have witnessed in the last couple of decades that there is tremendous increase in availability of ultrasound machines in all the operating theaters. And anesthesiologists have been on the front, and they have learned various procedures that is giving a block or putting in a central line or putting in arterial line using this ultrasound guidance. So these devices are available for us right now. And with the as the time has progressed, the anesthesiologists are now well versed with the knobology. They know how to get a good image. They know how to optimize a bad image. They know how to hold a probe, how to change the probe position. So basically, a very good introduction to this ultrasound machine is already there. So learning echocardiography just is one step away and getting in good views and getting good information from it. And on the top of it, as all of you will agree, that every single patient coming into any operating room nowadays has got a lot of comorbidities. So it is very common to see ASA grade 3, grade 4 patient on any list in any of the hospitals. So complexity of the patient, the demanding procedures, so they are increasing every day. And at times you will not have immediate access to cardiologist. You may not have, they may be on call, so you will have to wait for a cardiologist to come and give the clearance. So gone are those days. As one of my dear friends, Dr. Amit Dixit, says that this is the with as our prime minister is saying that it is Atmanirbhar Bharat. So he has given a terminology as Atmanirbhar anesthetist. So one anesthetist who knows everything about POCUS, who knows about echocardiography, is Atmanirbhar anesthetist. So because of this, every conference you will see that there will be a pre-conference or a post-conference workshop on echocardiography, and lot of younger and even senior anesthesiologists are now learning or relearning the art of echocardiography. So in our department, ozone anesthesia group, also we are planning to start a systematic program to give training about echocardiography. Another very important paper that I want to share here is focused cardiac ultrasound by obstetricians. So this was from a rural part of Assam and Meghalaya, and the obstetricians were given a brief 1 week training on how to obtain an image. And you will be surprised to see that obstetricians could pick up as high as 27% of the abnormalities. Like every 1 in 4 patient has got some, or a pregnant patient, of course, had got some or other cardiac abnormality, and they could very clearly do it as good as an expert cardiologist. So a brief training also can help in lot of our patients. So based on all this background, now you will be convinced that every anesthesiologist should be an echocardiographer. So in tune with this finding, the American Society of Regional Anesthesia has started POCUS spotlight series, and I'm very happy to share with you all that we were given an opportunity to present on advanced fate, that is advanced focus transthoracic echo spotlight series, and all 4 Indian authors had contributed to this ASRA spotlight series, and you can actually get an access, full access using this QR code. So coming to the topic proper, there are 3 important echo windows from which we can see the heart. First is subcostal, then parasternal, which is just next to the sternum, and third is apical, where actually the apex beat is there. So there are again 3 important probe maneuvers that every echocardiographer has to learn. The first is a tilting maneuver. Tilting maneuver is actually nothing but doing a tail up or a tail down maneuver, in which we can see right from the anterior-most structure of the heart to the posterior-most structure of the heart. So anterior-most structure of the heart is probably PA, and the posterior-most structure of the heart is coronary sinus. So from keeping it at one position only, if you do tail up or tail down, you can see with the help of tail down, you can see the anterior structures, and with the help of tail up, you can see the posterior structures. If you rotate the probe, your long axis image will be shifted to short axis image, or vice versa. So rotation is moving along the axis. So this is moving along the axis. So rotation can be clockwise or anti-clockwise. And the third important maneuver is actually sliding scanning maneuver, in which you actually change the intercostal space from one to the other one. So straight away coming to the subcostal view, whenever you are trying to learn an echocardiography, it is very important to know certain things. One is which patient will give best position to obtain that particular view. Second, where you will exactly keep the probe. So in subcostal view, you have to put it just below the episternum, subcostally. And third important thing that you should know is where your orientation marker is. So every manufacturer will have a different orientation marker. Some may have a green glow, or some may have a notch. So here the orientation marker is kept to the left of the patient. Patient is lying supine. And what you see is on the top, you see liver. Just below the liver is the right ventricle, then right atrium, and there will be interventricular septum, and the left ventricle, the mitral valve, and the LA. On the below this, you will see a descending thoracic aorta as well. So you will have to imagine this image when you do a subcostal view. So if you rotate the orientation marker from left of the patient to cranial, what you get is the subcostal IVC long axis view. So this view is very important to assess for the CVP, which we will see subsequently. Coming to the second important view, that is apical 4-chamber view. Here, what is most important is patient position is now changed, and patient is now put in a left lateral position with his left arm kept below his left hand, working as a pillow. So what this does is this increases the intercostal widening, and now the probe is kept at the where the apical impulse is felt the best. And in this, the apical 4-chamber view, your orientation marker is pointing towards left shoulder of the patient. And this is the classic image that we always imagine, that we see a left ventricle, right ventricle, RA and LA. So when we should call it as a good apical 4-chamber view is when you are visualizing the apex of the heart, when the interventricular and interatrial septum is vertically placed. So this is a very good view because it has got IVS and IS placed vertically. Okay, so at times you may not be as lucky. So particularly when you start screening initially, what you see is something like this. So here you are not at all seeing the atria. Okay, so that means the action which you need to do is tail down. So you need to look little anteriorly and you will get a good classic 4-chamber view. Or at times what you start seeing is the LVOT and aortic wall, which is a very anterior structure of the heart. So in that case, what you have to do, you have to do a tail up maneuver to look posteriorly and you will get good 4-chamber image. At times what happens is you are seeing a lot of RV, but the LV is not seen very clearly. Okay, so for this particular view, if you get this particular view, you have to move probe laterally and you will surely get a good apical 4-chamber view. Coming to the next view, that is parasternal long axis view. In this patient is again lying in the left lateral position. The probe is kept on the 3rd or 4th intercostal space, and the orientation marker is now cutting across mid clavicle of the right side. So this is probably the only position where your orientation marker is facing on the right right shoulder or right mid clavicular. And what you see here is on the top is RVOT, then interventricular septum, the left ventricle, the two leaflets of the mitral valve, the left atrium, the LVOT, aortic valve, and aorta. And below you can see a descending thoracic aorta. So this view is very important for doing certain measurements that we will see. From the same position where you have gotten plaques or parasternal long axis view, if you rotate the probe and now your orientation marker is facing towards the left shoulder of the patient, you get what is called as P-sax view or a parasternal short axis view. So this view is also called as a donut view because you are cutting across the LV at a papillary muscle level as if it is looking like a donut, and RV is on this side, this interventricular septum. So near your probe is the anterior wall. So various segments of the left ventricle are clearly seen in this view. So basically anterior and anteroseptal segments are supplied by left anterior descending, that is LAD artery. The inferior and inferoseptal are supplied by RCA, and the lateral segments are supplied by the circumflex artery. So in this single view, you can see for the regional wall motion abnormalities. So this view is very, very important and very crucial view for regional wall motion abnormalities. So now coming to some of the advanced or extended views. So here is this video which we had put in. So how probe is positioned. So if you see closely, this is the orientation marker. In the 4-chamber view, this orientation marker was facing to the left of the patient. So now if you rotate this anti-clockwise by 60 degrees, you start seeing a 2-chamber view of the heart, in which this is the anterior segment and this is the inferior segment of the heart. So if you move the probe anti-clockwise still more by 120 degrees from the 4-chamber view or 60 degrees from the 2-chamber view, what you see is the apical long axis view of the heart. So here you will see the LVOT and aortic valve coming into the picture. So from a 4-chamber view, which is this position, if you do a tail down or if you are looking more anteriorly, you start seeing a 5-chamber view. So you can see it here, the 5th chamber being LVOT, and you can see aortic valve coming into picture. So for parasternal window also, there are extended views. So we have seen about the mid-papillary view. So from if you move little anteriorly, you start seeing a mitral plane, and if you move even further, you start seeing the parasternal short axis view at the aorta. So with all these basic information on how to get the views, now we come to 5 important number or calculations that we do. So how we basically determine CVP based on echocardiography. So what we do is we obtain a subcostal IVC view, that is long axis view of the aorta. We put M mode cursor and we do a short sniff. So if the IVC diameter is less than 21 millimeter, and if there is respiratory collapse of more than 50%, the CVP is 5 or below 5. So if the IVC is more than 21 mm without any respiratory collapse, the CVP is definitely more than 15. So as you can see here, the normal diameter, that is 18 mm only, and with the sniff, it is coming down to only 6 mm. And as you can visually see here, so there is nice collapse which is happening with the respiration. So this patient is very likely to have CVP less than 5. Compare that with this patient who has got a IVC which is dilated, that is 28 mm, and it is hardly collapsing. So this patient definitely has got CVP of more than 15 mm, 15 centimeter of water. So coming to the left ventricular systolic function. So one of the most important thing that echocardiographer has to train his eye and train his mind, in which you can see here on the left side of the image, a very good left ventricle in which all the walls are contracting synchronously and coming nicely inwards, compared to the right side image in which half of the LV segments are not contracting, and even those who are contracting, they are not contracting as good. So this is called as hypokinesia on the inferior and the lateral segment, and almost akinesia on the anterior and anteroseptal. So you will have to train your eye and mind to get this information. So coming to some numbers, so in the parasternal long axis view, you have to put an M mode cursor just below the mitral valve leaflets, and what you actually measure is the internal diameter in diastole and internal diameter in systole. So in this particular patient, the diameters are shown here, and you get what is called as fractional shortening, which is given by this formula: internal diameter in diastole minus systole divided by diastole, and the fractional shortening in this case is 33%, and ejection fraction is roughly 2 times the fractional shortening, which is 65%, and normal in this particular patient. Another very simple measurement that you can do in any given machine is called as MAPC, or mitral annular plane systolic excursion. You obtain a 4-chamber view. You activate the M mode cursor and put it at the lateral mitral annulus, and you will see a movement which is troughs which are coming up and going down. So from the base of this to top of it, if you measure, that gives a value which is called as a MAPSE in centimeter or millimeter. So any value which is more than 12 mm is indicative of a normal LV systolic function. Similar to this fractional shortening, if you move your cursor towards the mitral leaflets, so you can see a movement of anterior mitral leaflet and posterior mitral leaflet. So distance from this is called as EPSS, or E point septal separation. So if this distance is very less, that means the LV is not dilated or not dysfunctional. So if a value of more than 7 mm usually indicates a LV systolic dysfunction. So our group actually had published this couple of years ago, in which anesthesiologists measured this EPSS, and we compared it against the gold standard of Simpson's biplane method, and we found an excellent sensitivity and specificity with good area under curve for this measurement. So this is very simple measurement that every single anesthesiologist can learn. Similar to our study, there was this paper in anesthesia analgesia, so and they measured both EPSS, which is distance between this leaflet and septum, and the MAPSE, which I described, and they said that all these parameters have got little different cutoffs, but the best one among them was EPSS with a very good sensitivity and specificity similar to our findings. So gold standard of ejection fraction, which is given by American Society of Echocardiography, is by Simpson's biplane method or by volume method. So we recently published another paper for giving a hint about diastolic dysfunction. I will not go into details of diastolic dysfunction, but if you obtain this tissue Doppler, activate this tissue Doppler and put it across the lateral mitral annulus, and if you see between the two below the baseline tracings, if you see one upslope that is above the baseline, this particular parameter is called as elastic recoil signal. And if this parameter is present, that clearly indicates that those patients are going to have a normal LV diastolic function. Coming to RV systolic function. So as for the LV, the RV, again, eyeballing is very important. Normally, the RV is 1/3 that of LV. So if RV is almost equal to LV, then it is said to be dilated. And if RV is bigger than LV, as is in this case, and RV is forming the apex, which is clearly seen here, that goes to say that RV is massively dilated and a RV systolic dysfunction is very likely. So how do we quantify it? We put in an M mode cursor again. For the MAPC, we had put it on the mitral annulus. So here for the TAPC, that is tricuspid annular plane, we put it on the tricuspid annulus, and a value more than 16 mm is indicative of a normal RV systolic function. So coming to the PA pressure measurement. So if we see, the cardiologist will always write PASP by TR jet velocity. So to get an PA pressure, first we need to see for the tricuspid regurgitation. So on the left side of your image, there is no TR, but on the right side of your screen, you can see a severe tricuspid regurgitation. That is a flow coming back in the right atrium. So if you put a continuous wave Doppler along it, you get a velocity and you get what is called as RV systolic pressure. So you have already measured a CVP when you were doing IVC measurement. So you add this RVSP to it and you get PA pressures. So in this particular patient, the tricuspid regurgitation velocity is around 4.75, giving in PA pressure of more than 100. So PA pressure assessment is very important. Can we measure cardiac output with echocardiography? Yes. So cardiac output is given by the formula of stroke volume into heart rate. The stroke volume is calculated by LVOT, that is LVOT area into length. So LVOT area we measure in the plaques view. I will just show you the images. And LVOT length, that is LVOT VTI, we measured in apical 5 chamber or long axis view. Those who are not doing echocardiography, don't get bogged down by these numbers or these calculations. It is very easy. It is simple physiology. You already know about it. So this is how you can measure cardiac output with echocardiography. You obtain a plaques view. Okay, then you pause it in mid systole when the aortic wall is fully open, and you measure the LVOT diameter, that is 2 centimeter in this case. Then you put in a color flow across 5 chamber view, and then you put a pulse wave Doppler at LVOT to measure this length or LVOT VTI, and machines will straight away give you this cardiac output and cardiac index. So far we know that we can obtain preload assessment by subcostal IVC M mode. We can do eyeballing and quantify LV systolic function. We can again do eyeballing and measure TAPC. Then we can look for the RV systolic function. We can measure the PA pressures by TR velocity, and we can measure the cardiac output. So most of the numbers, fancy numbers that you can very easily obtain with the help of echocardiography. But has artificial intelligence taken some low lead in echocardiography? Definitely yes. So just look at this handheld machine. It not only labels which chamber of the heart it is, it also gives you an idea. So this green bricks you can see here, they say that the image quality is good. Compare that with this red bricks in which the image is not good. The moment it is giving you prompts, slowly do this movement, and moment you get good image, the bricks from the red start turning into bricks into green. So that goes to say the image quality is good. And once you obtain good quality image, within say 5 seconds, machine gives you ejection fraction, machine gives you cardiac output, everything within. So this entire exercise takes less than a minute. So you can actually calculate ejection fraction and cardiac output in less than a minute. So once one company comes over, there are a lot of other companies. So GE has got one software in which it again traces the border automatically. If the image is bad, it will show a red or yellow. This is a red one, so image is not good. The moment you get good image, it will start giving you auto EF. So auto EF, auto tools are activated and you get auto ejection fraction. So is Philips company, which has come up with El Vivo app, and it gives you a stroke volume and cardiac ejection fraction within less than a minute. So has all these AI applications translated into evidence? So if you see, there is actually flooding of literature with the help of artificial intelligence in echocardiography. So this was a very initial paper published in 2020. So with the help of an handheld echocardiography machine, so the machine gives you one value, and it was checked consecutively in 100 patients by expert echocardiographers. So diagnostic accuracy was very good, and more so picking of LV systolic dysfunction, which is very crucial for us in perioperative period, was excellent with the help of this handheld echo with artificial intelligence. So subsequently from this, it was checked in a multi-center study. So this was a multi-center study of around 400 patients in which this focus examination by handheld echocardiography and transthoracic echocardiography, if you see, the ejection fractions are given absolutely same. So this gives a very good area under curve for detecting LV dysfunction and severe LV dysfunction. So you can and these were done compared against the standard machines. So anesthetist, can they do it? So this was done in a cardiac surgical theater. So if you have got a good image, and if you have got an artificial or a deep learning, which is an extension of AI, so if you look for the ejection fraction with adequate image quality, there was excellent correlation. But when the image quality was not good, probably there was not good correlation. So getting in good image is very important, and knowing how to obtain an image is important. So this paper actually has used a software which is between the machine and the operator. So again, this software gives you a hint like where exactly you should hold the probe, what should be the location, what should be the direction of the orientation marker, what is the depth that you need to keep. And this was done by novices. So it was given to novices, and subsequently expert echocardiographers checked for the quality and suitability, and they came that with the help of this image guiding by artificial intelligence, the novices could very well pick up the changes in the LV size, function, and so many parameters were checked, and the diagnostic accuracy was always there above 90%. So real-time image guidance is very, very important for novices. So that was about the ejection fraction. Can these devices help in valvular dysfunction? So we all know that aortic stenosis is a very serious condition, and with the help of this handheld machine, there are now ability to do all the measurements which a standard card-based machine can do, and it can give you excellent images. So these are on the bottom are the handheld device images, and on the top are the card-based or standard machine, and you can see that across all the severities, right, from no aortic stenosis to severe aortic stenosis, both the devices give very good similar results. And this was published in Journal of American Society of Echocardiography. So coming to this newer concept that even nurses can do home-based detection of cardiac dysfunction. So 5 novices nurses, look carefully, these are nurses, not even doctors. They were given 1 day training, just 1 day focused training, and they were just told to follow certain steps which they need to do. And look at this. So this AI-based focus examination was as good. It was having good sensitivity for the primary outcome, and it was far better than a pharmacological or a blood test that is NT-proBNP. So a nurse who has got a 1 day training, if she can do, definitely anesthetists who are well trained in so many things can definitely take over as echocardiographer. So coming to this last part of evaluation of aortic stenosis. So we had proposed, or rather it is already well established, of having IM approach. So any clinical condition is very, very important in which context anesthetist is doing echocardiography. We are not here to replace cardiologist as echocardiographer. Our aim is very specific. So this, suppose a very common scenario, an elderly patient who is supposed to undergo an urgent surgery, that is a hip fracture surgery, and on pre-operative assessment, anesthesiologist hears a systolic murmur. But there is some history of dyspnea on exertion, very vague history, and there is incomplete medical workup. So will you wait for this? No. So anesthesiologist himself can now do echocardiography, and he can acquire basic fate views. So that is IM. A is acquisition of basic fate views. So what are the important views that one has to know is plaques view, short axis view at the aortic valve, 5-chamber, and a long axis view. Let's see them one by one. So if you obtain a plaques view, that is parasternal long axis view, you can very clearly see that there is heavily calcified aortic valve with reduced mobility of the aortic valve leaflets, very clearly seen. So then you obtain a parasternal short axis view at the aortic wall. You can see it here, again very heavily calcified aortic valve with almost no mobility. In an apical 5-chamber view, again you see this calcification very clearly here. And if you put a color flow, and apical long axis here, heavily calcified aortic valve. So we have confirmed it in multiple views. Then you put a color flow across it with very low flow across aortic valve. And then we put a continuous wave Doppler, and you obtain a continuous wave Doppler trace, and you measure the gradients across aortic valve, which are clearly showing here 52 of mean gradient. Any gradient which is above 45 or 50 is labeled as severe aortic stenosis. So now anesthesiologist, this is actually our own case. So we have done, this echocardiography was done by anesthesiologist, and we could measure very high gradients across aortic valve. So we have acquired the images. So what you do after acquiring these images, so you make a medical decision. Okay, so we thought that, okay, let's not hurry up in this case. We will need a formal transthoracic echo and a cardiology consultation. So ultimately, cardiologist confirmed that there is severe aortic stenosis. So we did not postpone the surgery. The patient got operated in the same setting, but there were definite adjustments made in the perioperative management. We had put in an arterial line. We were ready for any hemodynamic deterioration with early vasopressor. We had kept an post-operative ICU bed reserved for this patient, and we could successfully successfully manage this patient. So here I would like to re-emphasize that we are not here to replace cardiologists. We are here to help our patients, and we are here to solve the puzzle of hemodynamic deterioration and pick them early so that we remain vigilant as this tiger which I captured in last week in Tadoba visit. So thank you very much.
Super presentation from Dr. Deepak on 2D echo.
Rajesh, you are muted.
Hello.
Yes,
Hello.
yes, Rajesh. Now we can hear you.
Yes.
Excellent presentations by Deepak and Samrat both. And
Thank you.
a few took us to future, zoom to future with your HPI, hypotension prediction index, and the focus in the OT. Yes. So there are some questions for you, Samrat.
Yes, yes, ma'am.
One question is there, the neurosurgeon is asking the blood pressure, he's wanting the blood pressure to be 80 by 50. So is it okay for a neuro case and for how long? Now the question they have put, but they haven't mentioned what is the age of the patient or whether the patient had any comorbidities, any carotid sinus problems. So this is a general question to you, Samrat.
Exactly, ma'am. So absolutely, I think you have answered it quite well instead of asking a question. So the age of the patient matters a lot. So there are three things in this question now. They are asking to keep the BP at 80 by 50, which is an absolute number. Now, the first thing is whether they are doing a continuous bit-to-bit monitoring or whether it is a non-invasive monitoring. If it is a continuous bit-to-bit monitoring, uh, you are sure that the BP is being monitored continuously. But if it is an intermittent BP monitoring, then there can be periods in between wherein you might miss absolute episodes of hypotension. So that is the first thing. Second thing is, as you said, whether the patient has comorbidities or no. Usually, old, frail patients and patients with comorbidities will not tolerate lower intraoperative hypotension, especially this induced hypotension, to a greater extent. Coming to the definitive answer, what should be the definitive numbers? If we go through the literature, as I've told in my presentation, there are no clear-cut definitive numbers. As of now, what we know according to the literature, mean arterial pressures of less than 65 mm of Hg for more than 20 minutes, definitely the patient can have problems in some or the other forms. It can be myocardial injury, it can be renal injury, it can be stroke, it can be delirium, or it can be 30-day mortality or 1-year mortality. So exact numbers we cannot tell. How long and how low, that is the question that will be answered maybe in the coming era or maybe in the coming decades. Hopefully, that is what I feel.
Yes, thank you, Samrat. Another question to you only. The incidence of renal shutdown in hypotensive anesthesia. Is there a known figure? What is the incidence of renal shutdown?
Renal shutdown. Okay. So if you talk about hypotensive anesthesia and especially in non-cardiac surgeries, then if you go across the literature, most commonly quoted study that I have also quoted in my presentation is by Walsh et al., in which he has studied around 33,000 patients. And in this 33,000 patients, he found that the incidence of AKI, that is renal injury, was around, I guess, around 5 to 7%. So maybe 5 to 7% of patients can have this acute kidney injury, especially when the mean arterial pressures are less than 55 mm of Hg.
It's a huge number, 33,000 patients they studied.
Yeah. He has done a retrospective study. Yeah. So that is a paper by Walsh et al. I have quoted in my presentation also. So according to that literature, it says around 5 to 7% of the patients can have AKI, especially when mean arterial pressures are less than 55.
Yes. So again, we want to limit the time duration of hypotension and the absolute value, or whether, I mean, can we say that 20% less than the pre-op or whatever that we used to say, commonly, keep it at 20% less than the pre-op? Is it, I mean,
So
does it hold?
the thing is, if you go by absolute numbers, then Systolic BP less than 90 is definitely detrimental. Mean arterial pressures less than 65 are definitely detrimental. Diastolic BP less than 45 is definitely detrimental. And if you compare it to the baseline, usually any drop beyond 30% from the baseline, that is more deleterious. And it also depends on how long is the patient being subjected to all this. So for example, if the patient has a mean arterial pressure of around 60 mm of Hg, literature says that the hypotensive episode can be sustained for around 20 minutes. But if this mean arterial pressure drops down to 55 mm of Hg, then the time for which the body responds or body can have homeostasis is around 10 minutes. So it all depends on the how long you are subjecting the patient and what are the pressure absolute values that you are targeting for.
And also, I think it is very important that which patient strata or which patient subgroup we are looking for. Suppose you are trying to look for an elderly 80-year-old hip fracture patient. So probably, definitely, I would never like to give him an hypotensive anesthesia. Compare that to a 25-year-old patient who is supposed to undergo, say, face surgery. Then probably we will definitely like to go little overboard and give him hypotensive anesthesia. So again, in clinical context, what we are trying to describe is very, very important, I think.
Yes, and
Absolutely.
suppose the hypotension happens, then what is your choice? Would you, I mean, because we are not doing the SVV or we don't have the cardiac output measurements. So are there any clinical guidelines that whether you give fluids or whether you blood or whether you start vasopressor and which vasopressor?
So basically, whenever hypotension is occurring, most commonly what all we have been trained till now through decades and all is firstly we give, if you don't have advanced monitoring systems like an echocardiography or maybe you say HPI monitor or this advanced parameters, usually the first thing that we do is we try to increase the preload of the heart and see at what part of Frank-Starling curve we are actually at. So if the patient is preload dependent, definitely giving a Trendelenburg position or giving a head low position will definitely increase the blood pressure. So that is the first thing that you do. Also, you can give small fluid bolus test or challenges, maybe in the form of 150 ml of fluid boluses. If the patient is responding to this, then definitely we can say the most probable cause can be preload deficiency. If not, we have to look into the further reasons, which can be either decreased contractility or it can be due to the afterloading conditions of the heart. For decreased contractility, definitely we would require some inotropic agents, maybe a dopamine or dobutamine in case of regional wall motion abnormalities. If suppose if you have a patient who has low ejection fractions, in that case, definitely dobutamine would be the drug of choice intraoperatively if you are having hypotension and especially when your preloading conditions are good. So that is the thing. If the hypotension is due to afterloading conditions, especially with the anesthetic agents which cause a decrease in the afterload and tend to cause some vasoplasia, definitely during in such subset of patients, alpha pressors like phenylephrine or maybe noradrenaline can be the drug of choice. So it all depends on the clinical situation of the patient and exactly what the pathology is.
Madam, can I answer this question?
Yes,
Because
yes, please.
because we just 3 days back we faced this situation. This is a real clinical scenario that has happened. Patient was supposed to undergo a straightforward micro disc surgery. Very expert surgeon. He'll say, "I'll finish in 35 minutes." It was late evening, and nobody was willing to give that case. But okay, anyways, he'll finish fast. We'll start. A usual story for everyone. So a patient was a hypertensive 65-year-old on regular treatment, preoperative workup absolutely normal, echocardiography was normal. So patient had got some history of some allergic reaction day before on the floor, maybe some sort of shivering or something. So patient was induced. First reading after induction was systolic blood pressure 90, second reading 70, third reading 50 immediately. So because we had a suspicion in mind that this patient had got some allergic reaction a day before, natural reaction was to give fluid. So we tried to give fluid, increase the preload, as Samrat was correctly saying. That was a natural instinct, and we gave some phenylephrine boluses. Absolutely no improvement in the blood pressure. So the next movement, we pick in the echo machine, take the echo probe. So you will not believe this was like a pre-arrest situation. The LV was hardly contracting. So what you expect in a patient who has got an anaphylaxis or anaphylactoid reaction is profound vasodilatation and a very completely emptying, squeezing heart or a kissing papillary muscle that we classically describe. So this patient was having a flickering heart. So immediately we changed our management. We gave him adrenaline bolus and we started him on NTG because the left atrium was full. This patient was hypertensive and he has got diastolic dysfunction. So LA was very full. So at the same time, we started adrenaline and started a NTG drip simultaneously. But within minutes, the patient again had a bradycardia episode and collapsed. We had to give CPR. Fortunately, the patient was already induced. So we shocked the patient. He required massage for good 10 minutes and we shifted patient to ICU and he definitely turned to have cardiac issue. So your intuitions may not always work better. So seeing it in black and white by putting, because I think anyone who has seen that echo image will never forget it for their lifetime, how a flickering heart, peri-arrest heart looks like. So it was a great learning for all of us that always, it may not always be true. So just seeing it is believing. So you have to pick up the probe if it is available wherever. You have to train your mind. You have to see various images and you can, fortunately that patient made a good recovery and I think yesterday only he got discharged. Thank you.
Excellent management, Deepak. So we all should go for focus, nothing else.
Yes.
And very nice answer to that. And real, these peri-arrest situations are very hair-raising. Very, very good management, Deepak. I
Thank
wish
you. Thank you.
we have people like Deepak around so that we don't have
Thank you.
problems.
No, madam, I
Okay.
think it is, I think other way, I think it exactly other way that it is now high time that there should be democratization of echocardiography. That is what they say, that everybody should be able to pick up the probe and get some basic views and get basic understanding. Like if the nurses can do it,
Yes, that was
or
so
if,
surprising that
yeah,
even
if the,
nurses who were given 1 day of training could do
exactly.
it. That was really surprising.
And obstetricians, if the obstetricians can pick up so many abnormalities, so I think we are definitely better placed than them.
Definitely.
Yes.
For Samrat, one question for you. Please comment on intra-op vasoplasic shock while coming off pump.
Okay. So basically, vasoplegic shock in cardiopulmonary bypass is a known entity. Uh, the incidence of vasoplegic shock is not much. I guess it is around 5 to 7%, but it can occur in a few subset of patients, especially patients who are with advanced stage or if they have comorbidities, patients usually with low EAFs, patients whose CPB time is more, aortic clot climb time is more, or usually patients who have redo surgeries. These patients can land up into vasoplegic shock. So when do we label patients as patient with a vasoplegic shock? Usually when the mean arterial pressure is less than 65 mm of Hg, when the cardiac index is more than 2.2 liters per minute per meter square, and when the SVR is low, that is less than 800 times. So these patients are labeled as patients with vasoplegic shock, and the first line treatment for these patients with vasoplegic shock is agents like, as I said, alpha agents, agonist agents like phenylephrine or norepinephrine is the drug of choice. In a few subset of patients, we can use vasopressin also. Few other drugs in vasoplegic syndrome, especially white coming off bypass, which are theoretical, are methylene blue. Some people have tried corticosteroids. Some people also recommend the use of vitamin C, but I have never used it. Most of the situations or most of this crisis is taken care either by noradrenaline or vasopressin.
Yes, and one more question to, I think any of you can answer. So induction hypotension should be treated immediately or wait for some time in frail patients? Means
Okay, in frail
time.
patients, so basically, frailty, as we say, is a recent concept which has come into place. So basically, frail patient means the patient does not have the physiological reserves in his body to cope up with the increased stress response either to the surgery or like this noxious events like intraoperative hypotension. So, if you ask my personal opinion about this situation in a frail patient who has induction hypotension, yes, definitely I would like to treat this patient. Depending upon the cause, especially post anesthetic inductions, the cause is usually a decrease in the afterload. So some drugs like phenylephrine or a small dose of noradrenaline can be started in this patient because these patients don't tolerate intraoperative hypotension to a great extent.
Yes, now and
Absolutely.
phenylephrine is available in vial, which we can immediately load and inject. So no need of time is not wasted in preparation of an infusion. There are no more questions, but I'm sure people here will have many questions. Yes, Vikas, can you find any more questions in the chat?
Because both the presentations were excellent, and
Yes.
I'm sure both of them, they are the torch bearers for focus, fate, and use of echocardiography and advanced monitoring devices in intraoperative period. I know both of them, and I also know their passion for cardiac anesthesia and also the hemodynamic monitoring and obviously the echocardiography. So it was excellent. I'm sure all of us have enjoyed it. I think I'll invite comment from Dr. Rajesh and Balaji sir.
I really congratulate both the speaker because they have presented very both topic very illustratively, and it is the now future for anesthesiologists. Every anesthesiologist must embrace echocardiography, and now probably in future we have to just learn how to acquire image. Rest thing will be done by machine probably.
Absolutely.
So this actually message we want to give to our audience, and I think both speaker are successful enough to give a strong message that each anesthesiologist must learn echocardiography. Thank you very much for presenting on this dais.
Thank you. Thank you, sir.
Thank you,
Thank
sir.
you so much. Thank you.
And the
Superb.
AI is there to help us. So
Yes.
we just
Yeah.
hold the probe. The AI will lead the way. That was
Yeah,
very
and it
interesting
is it is no more future. Future is already here. So
It's
we have
here.
Yes.
Yeah.
yeah,
Yes.
these machines are already readily available. Some of our
Thank you, sir, so much. It was very lucid presentation, and
thank you,
it
thank
was
you.
really because of Society of Anesthesia Practitioners. Really loved the presentation. I think many more people will get encouraged with and focus. Me, I like to learn focus as well as
Dr. Rajesh.
Yes, very superb presentation by both the speakers today, Dr. Samrat Madnaik sir and Dr. Deepak Borde sir. To Dr. Deepak, I would like to join as a first candidate of your 2D if you start
Thank,
from the ozone anesthesia group. Please
thank you.
note it that.
Thank you, sir. Thank you. I take it as a big compliment. Thank you very much.
Yes, yes. First of all, I am very much thankful to both the speakers. They have given a nice presentation on recent advances of 2D ecography and its uses. I'm also thankful to Dr. Balaji Asegokar, Dr. Anita Nete ma'am, Dr. Katkade sir, Dr. Avinash Bhosle sir, and Vikas Karne, and all the senior members of the SAMS and my friends who have joined this webinar today. Thank you very much.
Thank you once again. Thank you.
Thank you, sir.
Good night.
Thank you.
Thank you. Thank you.
Thank you, sir.
Thank you.
Very good presentations, and we had quite a good number. 54, around 55 people were, and actually, I think we should repeatedly put it because it could have been missed by many people. Should
Yes.
put it on various groups more frequently.
But still, it was a good number, and
Yes.
presentations were excellent.
Yes, yes, presentations were very good. And though it was, I mean, quite futuristic, but see, ultimately, you have to know what is happening around.
But as Deepak said, that it is futuristic, but it is now a present. So many of us now, even in our hospital now, echocardiography, intraoperative TE, even for non-cardiac cases, is becoming slowly a routine. And many of our colleagues, junior colleagues, are so much interested in all these things because that is the future, as you rightly said.
Yes, yes. And see, I mean, times are changing so fast that when we were in the college, things used to change after 12 years. They used to say, Eka tapanantar. Now, every 1 year,
It's,
I
it's
mean,
concept has changed.
very fast change is there, and we must embrace the change.
This change will be faster once the AI becomes the reality. It's already there.
Yes. So AI generated or AI enhanced USG images, that is the future. Yes. So yes, thank you, and thank you for attending. Good night, everybody. Bye bye.
Thank you, everyone. Good night.
Thank you, everyone.